Okay, I think it's time to get ready for the last session of the day. So I invite everybody to sit down. Thank you for joining us. So my name is Amy Abernathy, and the last session of the day, what we're going to talk about is how we can facilitate and leverage collaboration and information exchange in order to advance the story in immuno-oncology. We plan 4 20-minute presentations. First, Erik Perakslis is going to talk to us about sort of the basics of informatics. He's the Senior Vice President of Informatics at Takeda and previously served with the FDA. Following that, Mary Horowitz, who's the Chief of Hem-Onc at the Medical College of Wisconsin and also the Chief Scientific Officer for the CIBMTR, is going to talk to us about applying information exchange in the real world using a national registry. I'll follow that as a discussion from Flatiron Health, but it really more is a discussion about how we can think about clinical data exchange and creating an information infrastructure for that. And then finally, Steve Averbuk from BMS is going to talk to us about a ongoing pre-competitive collaboration to start to think about what really can be done, and a fascinating story there from Blueprint. So with that, Erik, thank you for joining us.
Hi, thank you. Erik Perakslis with Takeda and Harvard Medical School. No other conflicts to declare, although as we go through this, I've probably worked either formally or informally with everything I'm going to talk about, so just assume that I know all the folks in there, although I'm not getting paid by any of them. Probably never did. Seeing where they asked the IT guy to talk at the end of the day, I figured I better show some cartoons. Otherwise people are going to bail. But I think this is a slide that a couple things that I've taken. And I think one of the interesting things about disease today is that we kind of continue to break it up. And what I see a lot is kind of this. I see a lot of folks that have kind of dissected an organism and they're trying to put it back together to tell a story. And of course, the guy looking at the leg doesn't even know the guy looking at the elephant exists if your organization is big enough. So I think really where I'm going kind of with this is, what do we mean by trans-IT operability, right? I'm not saying it just because it can be a really complex or really easy question. So my advice is going to be, let's make it a somewhat easy question. There's actually been a lot done on this. There's been a lot done here. There's been a lot here at the National Academies. There's been a lot done in the oncology space. There's been a lot done in the philanthropy space. So I think, really what I say about IT operability is I think during this session, you're going to hear different versions of what it could be or should be. I think it's up for this community working on this specific problems to figure out what you would like it to be. So first of all, what should be interoperable, right? So you've got data coming from different places and it's different types of data. It's actually good for different stuff. I'm someone who I don't like the term dirty data. I think if we were trying to be accurate, we'd call it wild type data because it is what it is. It's what's coming in. And I think you got to work with it. You've got to acknowledge it. And for some things, of course, for an RCT, you're going to do things a certain way. Hypothesis finding, getting ideas, you do what you need to do. So I think really what we're talking about and what I do at Takeda and other places is it's okay if you have lots of data, all for measurements that have different types of precision. That's just math. You just do that part right. Other than that, it's creativity and imagination that makes you think. And I think, the idea here that the community care setting, academic medical centers, large hospitals, registry clinical trials and whatnot, there are actually gaps as we know in this. There aren't just gaps in the data, because I'm a renal cancer patient myself, and I actually carry everything around with me because I know wherever I go, they will not have all of it, no matter where it is, right? But I think the idea is there's gaps in thinking, there's gaps in what the priorities are. I think that's kind of important to think about. And how do you kind of make sure everything stays relevant to patient care? So talking about what's interoperable, I think in addition to the clinical settings, you've got lots of other things. One of the things, and I'm really tempted to write a paper on the bogosity of big data and what that really means or doesn't mean with Zach Kahani. We know we're going to do this. We just haven't had enough beer yet to do it. But one of the things that's interesting about right now, and this is even different than 15 to 20 years ago, is you actually really have to think about what data you're going to include in your analysis. 15, 20 years ago when I started at J&J, that wasn't as true. We had RCT data, we had the literature, and we had what's available to us. But today, there's so much stuff out there that you could use. You really have to think about it. And that's why I think data science is becoming more of a real science. And it matters on the expression. But, when you look at all the different types of data out there, there's text, language, and standards. They're all great, really important stuff to do. I'm actually somewhat of an agnostic when it comes to standards. I know a lot of people always get upset. Even when I was FDA, I used to say that, and the people didn't like, and I'm like, well, they're always asymptotic, right? So no matter what, they're never complete, and that's okay. It just means you can't rely on them for everything. You're always gonna have to be creative and say, these are the standards that I have today. I'm gonna use them. I'm gonna go solve the problem I have. Tomorrow they'll be better. I'm not gonna wait. Right? High content data, whether it's the public stuff or everything else, the amount of sequencing, imaging, pictures. My daughter's 14. The amount of imaging data in my house right now that has to do with 14-year-old girls hanging out is kind of amazing. And of course, we know that I get in trouble if I post any of that, and I never would, but it's still there. And then, the patient-powered stuff. And I think this is really the interesting stuff that's going on is the many, many ways people are finding their voice. One of my favorite studies here is one of the small PCORIs, the PPRNs, the patient-powered research networks that we had at Harvard, where on something called Phelan-McDermott autism. So you take autism, really complex, lots of different things going on there, spectrum disorder, the way the kids present and everything. This is a case where several women that had children with a very specific type of autism, Phelan-McDermott, single mutation, basically created a registry of like 90% of the worlds of these kids using like Facebook. It's only about 3,000 kids, but it's amazing how they could pull something like that together and get their population represented, and then go get several $1 million from PCORI to get a study done on that. So it's really impressive what's going on right now. And as a person in biopharma who spends way too much money on data, probably I'm very interested in that type of stuff versus what some of these big corporations can creep out. Linguistics, one of my favorite colleagues and next door roommate at Harvard Medical School is Alexa McCrae. Some of you may have heard of Alexa. She did clinicaltrials.gov. Interesting thing, she's a linguist. She wasn't a biologist, she wasn't anything. She's a National Library of Medicine. And way back when people were first saying that clinicaltrials.gov couldn't work, she realized it was a linguistics problem. And it was. And there's not just the language of different domains here. There's alignment, so what does study start mean? 30, 40 different definitions of study start, right? There's all those pieces, but the idea is that they're solvable. You should think about what your language issue is. And I think in a field like immuno-oncology right here, it's okay as you evolve to develop language and to use it. And the other thing is, how do you put the patient in the middle? That's something I'm struggling with. My head of R&D at Takeda would like me to do that. And I'm like, well, okay, so our data is organized by trial. It's organized chronologically, and most of it's in people's email boxes, which are organized by name and by date. So you're not going to find a patient in that. But you could think of organizing a filing cabinet the way a human is set up. And I really mean that because there's a lot of really interesting technologies out there that can do amazing stuff with data. If you keep your data into its simplest small components, you can actually do the most with it. And so the idea of a filing cabinet, if you think about most big cloud systems, the best ones are really just file systems with the right analytics on top of them. I can put lists in, I can take lists out, and I can manipulate lists. So keeping it simple here is really, really important. Everybody heard of a data lake? Don't fall in. Basically, it's something else when people stop talking about data, but it's a repository for large quantities of data, structured and unstructured. And a lot of times people now make data lakes because they're on their way to a data warehouse, which you've all heard of, and you probably have one or two that you love and more than that you hate. One of the interesting things about data warehouses, and some of you may have heard of a system called Transmart, which was a system that I developed at J&J, and then I gave it away. It's being used by a lot of people now and a lot of farmers around the world to do clinical data warehousing. I like this picture because the Rubik's Cube is nice. If you have your data in simple pieces, you should be able to do this with it, and you don't want to over-bias by a database design or anything like that. Like once you instantiate your questions hard into your data, it's less malleable. But if you can actually keep your data in a way where you can flip it, spin it, look at different angles on your patients, on your cohorts, on your biology, on your mechanisms, fibrosis versus, mechanistic axis versus a pathway, it can really, really be important to think about. So data warehouses is a lot of the way people bring their data together. So relative to oncology and relative clinical trials, this is just some, right? I bet you most of you can name even more than this. So I think the important point about a lot of these is actually most of these are pretty good. And when people come to me, I'll usually say is, please don't make another one. Please consider one of these, because they probably are 60, 70, 80% towards your use case. And some really good work has been done by a lot of people on these. They're different. They're definitely different for different things. But between the private sector, public sector, the commercial sector. There's a lot of amazing ways out there to bring clinical data and research data together that will more than likely do anything you needed to do. And if not, work with them. Because that's the other thing, when I've helped out or advised any of these consortia, they'd much rather you brought your use case to them because they're not doing it than find out that something else is going on. Because, you know, if you're a patient and your data is in all of these or some of these, what's the value of another one to you? Actually, there isn't, right? The value is if someone can ask a new question about your data. So it's about angle of attack. I'm a guitarist. I couldn't find a good thing on angle of attack. It's a matter of what type of questions do you have? Do you have consistent questions and use cases? Now, your IT guy is always going to say, well, what questions do you want to ask? And then you want to hit them, kick them, whatever. I've been attacked by both. But I think the idea here is, let me say this slightly differently. I think there's two things that are different now than they were 4 years ago. One is computation is still faster and cheaper than it ever was, you know, and continuing to be more commodity. The other thing is that the way most people are thinking about technology projects are different. Be completely impatient. Ask for something in a month and mean it. I used to say I would not approve or run an IT project that was more than 6 months. Then I went to 90 days. I currently do it at 30 days. If you've got 20 questions, why wait 2 years to answer them? What if you can answer the first question in a month or the next one in a week? You know, get something as you go. Don't let it go. Don't let this thing go on 5, 6, 7 months and you're not really sure what's happened. Bring the guy a cookie and ask him a question. Figure out what you'd want to do. The things you always need to know. Who's going to be asking the questions and how often? What do we want the data to tell us? And what should we be asking? And iterate between 4 and 5, because now with all the different techniques and the different computation services out there now pretty cheap, your data can ask and answer its own questions. It's not always that thoughtful, but it can crunch its own numbers. It can just run the permutations and figure it out. You can throw Watson on it. You can throw lots of things against data these days, if you keep your data in a kind of a low cost, simple format. And then you get to this stuff. We do get to this stuff, right? Different disease maps and drug interaction maps. You know, everybody can do this, but when I look at what's going on here, everybody just kind of looks at it. There's this great program we work with at the MIT Media Lab, and what it does is it can read all your faces, and when I switch the slide, it can tell me what the mood in the room is. And I can tell you, if I put an equation up there, the mood just goes red and it drops off. Every time. I've watched it with our people talk. But I think the things that you can do right now with a webcam in front of this room, it can also, they're getting to the point where they can tell pulse and blood pressure just by looking at the oscillation you can't even see in your skin. So the stuff that people can now do with this is getting impressive and getting more interesting every day. My last slide, how many people have ever seen the Gartner hype curve? It's a real IT thing. Read the different points in this curve. And I think it's something important to think about, but it's actually true. The peak of inflated expectations, the trough of disillusionment, the slope of enlightenment, the plateau of productivity. Most technologies, they actually do this with everything, with high throughput screening, with proteomics, they do it with different things. But it's actually, the interesting thing about it is it's actually usually pretty right. So I think the idea here is you get on that slope of enlightenment, that's how you select the technologies that you're going to use for what your problem is. You know, don't jump in too early, but don't wait too late. Figure it out. This stuff is out there. So that's kind of a primer or a little bit of, to get the blood flowing on IT interoperability. Thank you.